I'm the director of the Division of Gynecologic Oncology here at the University of Arkansas for Medical Sciences. I'm also an associate professor in the Department of Obstetrics and Gynecology and the Division of Genetics. Basically, a gynecologic oncologist is a physician who specializes in the care of women who have gynecologic cancer such as cervical, uterine, or ovarian cancer. I also have a special interest in the genetics of those diseases. That means, are there reasons why people are at increased risk for developing those cancers because of the genes they inherited from their parents?
And I'm Mindy Simonson. I'm a genetic counselor in the Division of Gynecologic Oncology. Dr. Zorn and I work together in the Hereditary Gynecologic Cancer Clinic. A genetic counselor is a master's trained professional that works with families that have inherited conditions to make sure that those families understand those conditions and get appropriate care and treatment.
We're here to explain our project that's working on increasing the number of patients who are at potential risk for an inherited cancer syndrome who get referred for appropriate genetic counseling and testing. This is a pilot project, which means that it's a new idea that we're testing how it works. Hereditary cancer syndromes play a large role in many common and deadly cancers. For example, in breast cancer, about 5 to 10% of it is felt to be hereditary in nature. For colorectal cancer, it's approximately 3 to 5% that's felt to be due to hereditary cancer syndromes. And with ovarian cancer, it's approximately 25% that is felt to be due to hereditary syndromes.
Genetic counselors and physicians with training in genetics counsel patients about the risk for these syndromes and guide them through the decision-making process about whether or not they want to be tested. There are national guidelines for who should be referred for counseling and for testing, and these guidelines are based on personal history of cancer, family history of cancer, age of onset, things like that. They help identify people who are most likely to carry a mutation, but the guidelines can be complicated and they change pretty frequently. So for example, these are just the guidelines for one set of cancer susceptibility syndromes for who should be referred, and you can see there's lots of different things that you have to remember, and if you're a busy clinician, you might not get all of that.
Identifying people who carry cancer-causing mutations can play a large role in their clinical management. For example, in a person who's already been diagnosed with cancer, it may change the treatment options. Perhaps more importantly, though, for people who haven't yet been diagnosed with cancer, we can take steps to screen to find cancer as early as possible, or possibly even prevent cancer from developing altogether. Examples of this include starting colonoscopy or mammography at a younger age to try to find a colon or breast cancer at the earliest possible stage. Other examples include taking medicines or undergoing surgeries to reduce the risk for cancer altogether. However, lots of people who need testing are not referred for genetic counseling and testing for a variety of reasons. These reasons include frequently changing guidelines about who should be tested, making it hard to stay up to date as a clinician. New and increasingly complex genetic tests, complicated rules about insurance coverage for testing, limited amount of time in the clinic setting to take appropriate family histories and schedule the referral, and a limited number of genetic counselors and cancer genetics professionals who are available for these appointments. Finally, it's complicated to coordinate appointments when people need to see multiple providers to manage their cancer risk.
So we're proposing to address this issue in our study. There are going to be two parts to our project. The first part of the project is the creation of a best practice advisory, or a BPA, which will be in the UAMS electronic medical record called EPIC. The BPA is an automated alert to an oncology provider when a patient's personal or family history meets guidelines for referral to cancer genetic counseling. This is going to be partnered with a second step, which is an improved workflow for managing those referrals so that each patient gets scheduled with the most appropriate provider and in the shortest amount of time possible. And this includes creating a coordinator position who can review and schedule people who get referred for cancer genetic counseling.
Part 1 is the best practice advisory. When a patient is being seen in an oncology clinic at UAMS, the BPA will trigger a pop-up box in the patient's chart if there are features where genetic counseling and testing would be recommended. This lets the healthcare provider know that the patient meets criteria for genetic counseling and testing so that they can enter an order for the referral if the patient desires.
So here's an example of what that might look like for a patient in clinic.
So do your parents have any history of cancer?
My dad did not, but my mother did have breast cancer.
Okay. And do you remember how old your mom when she was diagnosed with cancer?
So I was 12. That would have made her 42.
Okay. Thank you for that information.
Sure.
Okay, so according to this, according to your family history, you may be at an increased risk of having an inherited cancer susceptibility syndrome.
What does that mean?
Well, there might be something running in your family that would make you or your family members more likely to get cancer. And when we find people that have that, we can offer things like more frequent cancer screening, or we can offer things to decrease the risk of developing cancer in the future. Would you be interested in speaking to a genetic counselor today?
Yeah, I remember how hard it was for my mom when she had her breast cancer. And I worry about my kids too. I really would be interested in that.
Okay.
We will talk to the people in each clinic about how to make the BPA work best for their clinic, including both physicians and nurses. We will also send out emails to the providers explaining the purpose of the BPA and create a tip sheet for them to understand how to use it. The goal is to make it as easy as possible for the providers who see the BPA pop up to follow through on ordering the genetic counseling that is recommended.
So the second part of the project is streamlining the referral process. We want to hire and train a medical assistant, or an MA, to review the referrals and schedule patients to see the most appropriate providers. Many of our different genetics providers have different areas of expertise, so we want to make sure that patients see the person who's best for their particular situation. Rather than ask the referring provider to try to figure that out, which is sort of what we've done in the past, we will have the coordinator take care of that for them. This should allow more people to be seen in the right clinic setting and get people seen a little bit quicker. The MA will also be able to schedule other appointments for the patient. So for example, if the patient needs a breast MRI or a mammogram, the coordinator will be able to schedule that to coincide with their clinic appointment.
We think that we can get part 1 and part 2 done in 3 months. The people who work on our electronic medical record think that this is reasonable for the development of the BPA. They are collaborating with us on this project. We can also train the coordinator while the BPA is being developed so that he or she is ready once the BPA is implemented. As the final step of the project, we will assess how the BPA and improved referral workflow steps are working. This is called an implementation project because we are trying to implement or put into practice the guidelines about who should see genetic counselors for genetic counseling and testing. We then need to see whether that implementation strategy is working. If it's successful, we'll be able to judge that in 2 ways.
We'll track referrals for 6 months after the BPA and coordinator are put in place. We'll compare the number of referrals that were made before and after the changes. We also will track how many of those referrals were appropriate because they met the guidelines for referral. We don't want to see people who don't really need genetic counseling and testing being referred, just the ones who do. We'll also interview anonymously at least one doctor and nurse from each clinic that implements the BPA and get feedback from them. We'll analyze those interviews to see if there are common ideas running through them. We expect this process to occur in the last 3 months of our study.
So what will we do with our results from this? We want to expand this concept so that as many patients as possible are identified who need referral for genetic counseling and testing. There are 2 basic areas where we think we could expand easily. The first would be to target other providers at UAMS beyond just oncology providers. This would be particularly important for primary care providers such as family practice, internal medicine, and OBGYN providers. The second target would be to expand beyond UAMS so that we're getting to providers across the state. Our goal for this would be to work with the regional programs that UAMS has set up. These programs reach all across the state and allow us to target, again, a broader range of providers, but also ones that are using a different electronic medical record than we use here at UAMS. With the pilot project completed over the next year, we would use the data gained from it to compete for funding at the national level. For example, the National Institutes of Health, or NIH, have funds that are specifically set aside for projects working in the dissemination and implementation area of cancer genetics research. We appreciate your consideration of our proposal. We think that using an automated alert in the electronic medical record system to help identify families at risk for cancer genetic syndromes and get those families appropriate care to reduce their risk for cancer has the potential to save the lives of many Arkansans and at the same time position UAMS at the forefront of genetics and medicine. Thank you for your time.